A healthy human cell operates on a precise biological baseline, a perfectly balanced 46-chromosome karyotype. When that architecture is compromised, even at a microscopic level, it sends predictable shockwaves throughout human development. This hand-written hierarchy maps out the primary branches of genetic disease. Diagnostically, conditions fall into chromosomal, Mendelian, mutations, mitochondrial, or multifactorial categories. Zooming in on chromosomal disorders, the pathology splits into two distinct mechanical failures: structural defects, where the chromosomes physically break, and numerical defects. Mastering how these specific chromosomal errors manifest clinically is foundational for the PMDC and RE exam. Structural defects occur when the physical architecture of a chromosome breaks and misassembles. These diagrams illustrate the mechanics of translocation, where a segment tears away from one chromosome and attaches to a different one. A Robertsonian translocation is a specific, high-risk variant. Here, two distinct chromosomes, typically 14 and 21, fuse directly at the centromere. Deletions involve a permanent loss of a chromosomal segment. If the short arm of chromosome 5 is deleted, it results in cri du chat syndrome, recognizable clinically by a distinctive, high-pitched vocalization. Inversions occur when a segment snaps off and reattaches upside down. Paracentric inversions happen beside the centromere, while pericentric inversions include the centromere in the flip. These physical breakages cause severe developmental issues. However, the most frequently tested Board syndromes involve a different failure: errors in how entire chromosomes are sorted. This page defines the math of numerical defects. Euploidy is an exact, healthy set of 46 chromosomes. Aneuploidy means an abnormal total number. It's almost always caused by non-disjunction during meiosis, leading to a missing chromosome, monosomy, or an extra one, trisomy. During meiosis 1, homologous chromosomes should divide evenly. In non-disjunction, they fail to separate, dragging both copies into a single gamete. Alternatively, the failure can happen later in meiosis 2, when sister chromatids fail to pull apart. When one of these defective gametes forms a zygote, that initial sorting error doesn't stay isolated. It is permanently replicated into every single cell of the resulting human body. Applying aneuploidy to the sex chromosomes, these notes detail Turner syndrome, defined strictly by a 45-X karyotype. The missing X chromosome produces a highly recognizable clinical phenotype: short stature, a webbed neck, and a broad, shield-like chest. Internally, the lack of a second sex chromosome causes gonadal dysgenesis. The ovaries become fibrosed streak ovaries, causing primary amenorrhea. Without estrogen, the negative feedback loop breaks, and the pituitary continuously pumps out FSH and LH to try and stimulate the gonads. You must also look for associated systemic anomalies, specifically a bicuspid aortic valve, coarctation of the aorta, and a horseshoe kidney. Despite missing an entire sex chromosome, Turner syndrome is the only monosomy compatible with human life. Conversely, Klinefelter syndrome is driven by an addition, an extra X chromosome, resulting in a 47XXY karyotype. The physical presentation includes tall stature with disproportionately long legs and the development of breast tissue, known as gynecomastia. The extra genetic material damages the testicles, causing primary hypogonadism, severe oligospermia, and infertility. The damaged Leydig cells fail to produce adequate testosterone, creating an estrogen-dominant hormonal environment. As a result, this specific high estrogen, low testosterone environment creates a uniquely high risk for male breast cancer and osteoporosis later in life. Shifting from sex chromosomes to the autosomes, we look at the most common viable aneuploidy, Down syndrome, or trisomy 21. This section outlines 3 pathways to trisomy 21, 95% from meiotic non-disjunction, 4% from Robertsonian translocations, and 1% from mosaicism. The classic physical presentation includes a flat facial profile, prominent epicanthal folds, a protruding tongue, and a single transverse palmar crease. Internal complications are severe and often require immediate surgical intervention, notably atrioventricular septal defects and duodenal atresia. The incidence of meiotic non-disjunction, and therefore trisomy 21, correlates directly with advanced maternal age. For the boards, know the long-term clinical associations. Down syndrome patients face an increased risk of acute leukemias and the early onset of Alzheimer's disease. Moving to the adjacent notes, Edwards syndrome is trisomy 18. Look for a prominent occiput, an unusually small jaw, low-set ears, rocker bottom feet, and clenched hands with overlapping fingers. On the next page, Patau syndrome is defined by trisomy 13. The extra 13th chromosome severely disrupts midline structural development, leading to microphthalmia, cleft lip and palate, holoprosencephaly, and extra digits. Both Edwards and Patau syndromes result in profound congenital anomalies. Survival beyond the first year of life is rare. To diagnose these accurately under time pressure, you must compare the karyotypes, features, and complications side by side. Turner is 45X with streak ovaries. Klinefelter is 47XXY with high estrogen. Down is trisomy 21 with early Alzheimer's risk. Edwards is trisomy 18 with clenched fists. Patau is trisomy 13 with midline defects. You must know the immediate visual triggers for the exam: webbed neck, long legs, single palmar crease, overlapping fingers, cleft palate. Recognize them instantly. If a 16-year-old female presents with primary amenorrhea, a webbed neck, and high FSH levels, you already know the karyotype.